morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, Executive Vice Chancellor for the University of Kansas Medical Center. This is Open Mics with Dr. Stites, and yes, I am that weird guy in that t-shirt you saw in the opening. You've heard me say it before, early detection saves lives. Today, we share the story of how a routine heart scan meant to protect the heart ends in a lung cancer diagnosis. Mark Dwyer has a family history of heart disease. His cardio score showed his heart was perfect. I wish I could claim that. I can't. His lungs, though, not so perfect. Two of Mark's doctors are joining us today. Interventional pulmonologist Dr. Michael Postigo, and from our Olathe campus, cardiothoracic surgeon Dr. Ashley Mann. We'll hear from you both shortly, and thank you guys both for being here today. But first, let's see the surprise that was hiding in Mark's lungs. Not exactly a Christmas present. Here's Alexis Tell-Sid.
If it wasn't for Mark Dwyer's incredibly persistent wife,
she was bugging me to, you need to do that again, you need to do that again.
A scan that led to a stunning surprise.
Got the call from my physician saying, well, got good news and bad news.
And one heck of a care team.
It was quite a journey to get there, though.
Mark would not be alive to tell his journey, which begins with some history.
My family, especially on my dad's side, has a horrible cardiac history.
So in February of 2024, at his wife's urging, Mark had a cardio score done at the University of Kansas Health System Olathe campus. The good news, his heart was great. The bad news, his primary care doctor, Mariah Andrews, said the scan showed a suspicious spot on his lung.
I've never touched a cigarette in my life, and I have lung cancer, potentially.
Obviously, he kind of was a little bit scared and shocked at first, not kind of knowing with that uncertainty going forward.
Dr. Andrews immediately referred Mark to the University of Kansas Cancer Center's Overland Park location for more scans. Then Mark was told he needed a special type of bronchoscopy not available everywhere.
It was so far down into my lung that a normal bronchoscope can't reach it.
Mark worried he would need to travel hundreds of miles from home for the procedure. It turns out he didn't even have to leave the health system.
We did a robotic-assisted bronchoscopy using our Ion robot that allow us to diagnose him accurately and safely.
Interventional pulmonologist Dr. Michael Postigo works at the health system's KCK campus.
Actually, we are one of the leading organizations in the country.
And he got Mark in right away.
The fact that we were able to kind of get him plugged in so quickly, I think, is one of the strong suits of our health system.
Unfortunately, the results confirmed Mark did have lung cancer.
That's when the decision was made, okay, we need to do surgery. We need to go in and get this thing out.
And the surgery would also be specialized robotic surgery not offered everywhere.
I had other people telling me, you need to check out cancer centers and other places.
And Mark again thought he'd have to leave home for treatment until he talked with health system cardiothoracic surgeon Dr. Ashley Mann in Olathe.
And I said, no, we can do this here in town. And I think that was really important to him, to be able to stay close to home for his care, but to also know that his home had that kind of upper level care that he really wanted.
I told her on the phone, I was like, well, that's all I need to hear. You're my surgeon.
Dr. Mann performed a robotic-assisted lower left lobectomy.
She was amazing. She was confident in her skills, which makes us confident in her skills.
And just one day after surgery, Mark was home. 2 weeks later, he was back to work full-time and going to the gym. The entire 6-month journey.
It was all either in town, right where we lived, or, literally just right down the street. My wife and I were just like, wow, you guys are awesome.
There was so much collaboration that needed to happen, from primary care to pulmonology to interventional pulmonology to thoracic surgery to oncology.
I think collaboration in medicine is more important than it has ever been. One person doesn't know everything. You can't be an expert in everything.
Just being able to deliver this kind of care to people, give them hope, let them know that they're in good hands, and that we will help you get through this, and we will help you get back to life. You should feel proud about that.
That's just awesome. Now, Dr. Postigo, Mark's lung nodule was found during a cardiac calcium score. This is something we are seeing more of as imaging becomes more sophisticated. How do you evaluate the importance of finding this in someone with no smoking history and no symptoms?
Yeah, absolutely. Actually, they have become super important. We know that people are going to the emergency department with, a fall, or they have, a trauma or something like that, and they're getting a CT scan, or they're going to see the cardiologist for evaluation of coronary artery disease, and they're getting a CT scan. We're actually finding quite a few lung cancer on those scans. We call it incidental pulmonary nodules. They are, patients are going for completely different reasons to get the CT scan. We get the CT scan, we found that nodule. And it's super, super important that we follow them, and the ones that are suspicious, they get to the right person to get them biopsy and then potentially start therapy. Lung cancer remains a huge problem. It's the cancer that kills most Americans. When we combine the other, common cancers like breast, colon, and prostate, lung cancer kills more Americans than those three combined. So, those scans are, even though we say, you are unlucky that you found that nodule. Actually, I think that you were
really
lucky. You were lucky that you got the scan, and we were able to find it earlier. And then, we have wonderful thoracic surgeons that can take it out. And, now he's back to his life, and hopefully with that cure disease, right?
Well, you saw that photo with his young children. I was one of those children one time. My mom was 52, and she was diagnosed with lung cancer way advanced, and I lost her when I was 19, and she was diagnosed when I was 17. And you look at those pictures, you think about that family and what an impact that had on him, and it was really fortunate all the way from, because again, we didn't even have like CT scans and advanced bronchoscopy and things like that back in the 1970s, so we've come so darn far. Again, science is real. Science actually is powerful. Mark was told the lesion was too far out in the lung for a typical bronchoscopy. Now, tell us why these type of lung nodules are so challenging. Like you and I know, but I don't know how everybody else knows.
So, imagine lungs are like these, like huge trees, and we have these very, very small branches. Before 2019, that when this technology was approved, trying to get to those like very distal branches was extremely, extremely hard. Also, when we are trying to biopsy those nodules, we need to remember, we need to keep breathing, right? So those targets keep moving. So they become quite challenging in order to have an accurate diagnosis. Robotic bronchoscopy has allowed us to do it safer, to do it more efficient, and to reach places that before we were not even dreaming to get.
Yeah. Now, you use that robotic-assisted bronchoscopy to reach and to biopsy the lesion. That's also a pretty cool story with all the technology, all the things spinning around. I'm like, okay, when I started as pulmonary medicine, we were doing it like this all the time. We didn't do that kind of stuff. But from an accuracy standpoint, how does the technology compare to the technology you started out with like a CT-guided needle biopsy or something like that, or going through the side of the chest wall?
So, it really have changed dramatically. Since 2018, when I think that we need to talk about different aspect of this technology. One is accuracy. Yeah. I think that is even more accurate than CT-guided biopsy now. Safety, when we look at that, the biggest risk of having these biopsies will be a collapsed lung. Even though it's not the end of the world, the chances of developing a collapsed lung with a robotic-assisted bronchoscopy, at least in our institution, is under 1%, versus 15% with that CT-guided biopsy. And having a major complication is almost non-existent. And I think that another very, very important part is that during the same procedure, I can also look at the lymph nodes in the middle of the chest.
Right.
So I can have an accurate staging. So by the time that we are done with the procedure, the patient is diagnosed, and we know what is happening in those lymph nodes, so we can potentially accelerate the treatment or having a more accurate treatment for the patient.
So a non-smoker, why did he have lung cancer?
Unfortunately, 20% of people that develop lung cancer have never touched a cigarette. They have haven't been no one in their family that had smoke in the house. And actually, things that are extremely important, just 20 to 25% of people that have lung cancer are active smokers. They are the people that has smoked for 5 years during college and then they never touch a cigarette again, and they are developing lung cancer. So that's why lung cancer screening is super important.
So can we follow up on just that point for a minute? So like my parents smoked really heavily. I never touched a cigarette. Should I be getting screened?
I think that the guidelines haven't catch up to that, but yes, I think that this screening is evolving, and I think that guidelines are going to be refined. At least we have something now that can focus on really high-risk people. But yes, you have a family history, and you were exposed to smoking.
Oh yeah, well, I called car windows up on those cold days, but the smoking did not stop. All right, Dr. Mann, once Mark's lung cancer was confirmed, the conversation moved to surgery. A robotic-assisted left lower lobe lobectomy. Why isn't this available in more places? And tell us what it is.
Yeah. So that technology is kind of up and coming. It's been around for a little while, but it's pretty sophisticated and it's fairly expensive, so not all centers have access to it. But now we're getting to the point where it's starting to show up in training, especially in chest surgery training and the cardiothoracic fellowships. We're seeing it more and more. So I'm hoping that more and more people are going to have access to it. But right now, like I said, it is kind of the newest technology. But the advantage is it's so sophisticated and good that it offers so many advantages to the patient. So the procedure that we did on Mr. Dwyer was a robotic-assisted left lower lobectomy, as you said, which involves multiple small incisions through the side of the chest. And then that allows us to do all of the dissection, all of the removal of that particular piece of lung that we're taking out through those small incisions. So minimizes pain, it minimizes downtime. As Mr. Dwyer himself will tell you, he was only in the hospital for overnight and did really well. And that's not an unusual story for our robotic lobectomy patients.
That is impressive that he could go home the next day. I mean, I've been in medicine for approximately a very long time, and left lower lobe removals didn't go home the next day historically.
Oh no. Oh no.
Big incision, taking it out, sewing it together, chest tubes, hoping it didn't leak. Yeah. So this is a lot better. Now, what made Mark a good candidate for this as opposed to the standard technique?
Well, the great thing about robotic surgery is that really most people are going to be good candidates for it. As long as you have enough lung function that your body can handle the loss of that one particular piece of your lung, most people are going to be excellent candidates for it. And in fact, it kind of works the other way around. Instead of saying, well, are you a candidate for a robot? For most people, the what we call the old school incision, the big incision across the side of the chest where you actually spread the ribs, that's a tougher surgery to recover from. So really more people are going to be a candidate for the robotic surgery than you want them to be a candidate for the original, what we call a thoracotomy, the big incision surgery.
Well, if you don't, because the lungs are kind of fragile, it's like a bunch of little balloons. If you don't have an air leak in there, that's pretty impressive after that robotic surgery. And then the pain looks like it must be a lot better because you got to go home.
That's right. Pain is significantly better because you don't divide muscle like the way that you do in the bigger incision, which is a big source of pain and discomfort for most of our patients. And that ability to just get up and have good pain control means that you breathe better and your lungs recover faster and then you recover faster. So overall, the robot for lung surgery has been a huge positive for us.
It has been remarkable. It's kind of like what you're doing, Dr. Postigo, what you're doing, Dr. Mann. All of this comes back to the development of new techniques through science and clinical trials to show that it's helpful. What a remarkable change. Again, I've been around so long. We're going to talk to one of our cardiologists in just a minute. We used to let people have heart attacks. We used to have to take people to big surgeries in the operating room, and we never used to find lung cancers until it was too far gone. So it is just so amazing to me. So Dr. Postigo, timing is important to know. Mark was referred and diagnosed really quickly. Talk to us a little bit about that importance of speed, not just for his own anxiety, but for his treatment plan.
Absolutely. So again, talking about lung cancer, unfortunately, despite of the advances that we have now, the survival is not great, right? Like just 25%. So 1 of every 4 people that I will be diagnosing today will be alive in 5 years.
Yeah, that's not great.
And I think that, this technology, robotic surgery, is helping to move the needle and potentially give these patients a better survival. From the time that nodule is being found to the time that the patient gets treatment is extremely important. We believe that if you find it early, actually, patients are going to do much better. So again, trust on the medical community, trust on your primary care. If they tell you, yes, you need to get a screening, actually that had potentially saved your life and prolonged, your life by many years. If we found it earlier, you have a chance of being cured of lung cancer. If we find it in later stage, unfortunately, the therapies are not great and the survivability is not great.
I think that's a really important point, because once cancer spreads into the tissue beyond that nodule or to other parts of the body or into the lymph nodes, our treatment plans are still not great for lung cancer. This early detection makes such a difference. And Dr. Mann, this really highlights the importance of this multidisciplinary collaboration. I mean, I feel blessed to have been here for so many years working with amazing teams, but you talk to us about what being a team member of something like this and how it can change surgical planning and the outcomes of patients.
Well, in Mark's case, we got lucky because we were able to catch it so early. And so the pathway was really just about getting him from the first right person to the next right person to the next right person. But we aren't always so lucky to catch them that early. And in those cases, that collaboration becomes even more important. For example, if we catch at, say, an intermediate stage, and maybe what will benefit you most is to get a round of chemo and radiation before you go to surgery. And in those situations, that collaboration is even more crucial because you need to meet with your oncologist, and then you need to meet with your pulmonologist, and then you come back to the surgeon after you've completed that, and then you go through that surgical therapy, and then you may need more chemo or radiation at the completion of that. And so it's not just for those early stage cancers that the collaboration is important. It's really as you go down the line at any stage, you need to have good collaboration between your teammates, because that's how the magic happens.
All right, well, thank you. And we are here to answer your questions. Send them using the links on your screen, YouTube, Facebook, or email the Medical News Network. This morning, we have a special guest and a special morning rounds. We are talking World Cup soccer right here in Kansas City. Our health system is the official medical services provider for the Kansas City World Cup 2026 host city, providing first aid to spectators and helping with direct medical care planning. Dr. Brian Beaver is here to discuss all of it. Good morning, Dr. Beaver, sir. How are you?
Good morning, Dr. Stites. Doing great.
Excellent. Now, we are expecting healthcare-wise, or what are we expecting with all these additional fans coming to Kansas City? It's like 650,000 people. We are doubling the size of Kansas City.
Absolutely. As you mentioned, we're expecting somewhere over the course of those 6 weeks of the World Cup to have somewhere around 650,000 visitors that we're very excited to host here in Kansas City. And when we look at all those visitors coming in compared to what we're doing today on a day-to-day basis of healthcare utilization all across our region, we're expecting somewhere around a 6 to 8% increase in healthcare utilization. Now, the good news for us is when we look at comparing to prior major events like other World Cups, the Olympics, those sorts of events, most of that we would expect to be minor illness and injury is what we'll be looking at and what we're preparing for.
All right, so are we prepared? Are we ready? What have we been doing to get prepared for this big event?
Absolutely. We have had a team working just on the health and medical aspects of preparing for the World Cup and hosting all these visitors for well over a year now. And that team has incorporated hospitals, health systems all across the region, our EMS partners, our public health partners, our community partners. We've had everybody at the table to make sure that we are well prepared to take care of those 650,000 visitors that are going to be coming in, but also ensure that we have everything in place to continue to provide the world-class care that we do every day to our residents who call Kansas City home.
Okay, so now what's the big healthcare message we're trying to tell all our visitors? And I'm going to guess what I'm going to know what I'm going to say, but I want to hear what you're going to say. You're the ER doc.
Absolutely. Our big message that we're working and getting out through as many avenues as we can possibly leverage to our visitors coming in is, number one, just how to understand the healthcare system in the United States.
Yeah, good luck with that one. That's great.
Exactly. For folks coming in that might not know the difference between an urgent care and emergency department, or they may mean something different in other countries, we're really trying to help them, number one, know when to access care, how to access that care, how to get to the right place. And then our other piece is some of our friends that will be coming to visit us may not be from areas that are quite as warm as Kansas City can get in June and July.
Yeah,
so we're also doing a lot of messaging around heat illness.
Hydration, 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 and that doesn't mean only with alcohol.
Correct.
You got to have a little bit more diversification about what type of liquids you could consume. Now, you're going to be out at Arrowhead Stadium a lot.
Absolutely.
Right? Now, I know there's not a lot of lodging right at Arrowhead. Are you pitching a tent?
You know, I have considered pulling my travel trailer over someplace in the near vicinity just so I can, you know, get a little more sleep. But no, we're
And if you're not using it yourself, I bet you could rent it out pretty high, right? You should VRBO that baby.
It sounds like there's a lot of opportunities out there for Airbnb and VRBO right now in Kansas City.
All right, no matter what you're doing, though, make sure you stay safe, make sure you stay smart, make sure you get really well hydrated. Remember, Kansas City in July, that's a hot time in the old town tonight. All right, we know many of you have questions. Let's head to Studio B with Alexis.
Have people still baffled that you can get lung cancer without having been a smoker. Dr. Postigo, did you say 20%, only 20% of the cases of lung cancer were from smokers?
No. 20% of lung cancer are patients that have never touched a cigarette, or
And
they
that's
have not exposure to smoking, which is, you know,
still a lot.
is still a lot.
And it's
2 out of
kind
10.
of one type of tumor, right? It's literally, it's the adenocarcinoma, which unfortunately can be some of the really hardest to diagnose, and they present kind of late.
Absolutely. And you know, it's really hard. Like, you don't think that you say, I have never smoked. Why will I have lung cancer? We think that lung cancer is just for people that had to smoke at some point.
Right.
Right.
It's like people who get, say, a stomach cancer or colon cancer, they may have never smoked. We think lung cancer can only occur because you smoke, because the injury is the smoke. But there are other sources of injury in our environment besides only cigarettes. Yet 80% of cancer is directly related to smoking. Let's not forget that side of the equation. But for this other 20%, you can still get lung cancer.
Absolutely.
Along those lines, Jennifer wants to know, what are the other things that can injure your lungs in addition to the smoke?
You know, we have some environmental exposures, like, you know, like pollutions. We have radon here, you know, in Kansas. You know, that
Lots
check
of
your
radon
basement.
in the basements, patients home. You remember, you have to do that radon screening when you go to buy a house, right? And they're supposed to present you with a radon certificate to say that that house, especially the basement, doesn't have a lot of radon.
Absolutely, absolutely. And you know, like, don't forget about, you know, some genetic problems. So is your mom, is your dad, or your brother develop, you know, lung cancer? There's probably something there, so we need to be careful with those ones.
I want to just point out too. Okay, one quick political ad, but it's not really a political ad. It's an ad for science. You know, in the 30s and 40s, when we didn't have the Clean Air Act, there was a lot of lung cancer coming about more from a pollution aspect, not only asthma and emphysema, but also cancer, because pollutants do matter in the air. So another reason, make sure that the air you breathe, you want it to be clean air.
Teresa has a question for Dr. Mann. Teresa wants to know, Dr. Mann, why is it that the surgery and the procedures you perform aren't done everywhere? Is this rare?
It's becoming less rare. I think the big hurdle for a while was just that it was a new technology, and sometimes new technology can be a little bit scary, but we've got so much good data on how effective the robot is now that I think that part of it is not so much the issue. Unfortunately, a robot's expensive. It's not a cheap system, but it offers so much benefit. So once you actually have a system that can get a robot into their facility, they find a lot of uses for it. It's such a wonderful technology. So even though we don't see it everywhere, I think as time goes on, you're going to find that it's going to become almost the gold standard of care.
And we had it here.
That's right.
All along with Dr.
Right.
Mann. And Dr. Postigo had the other procedure that other people might have had to drive far away for. Derek wants to know, how did you determine that Mark didn't need chemotherapy or radiation?
Yeah, you know, depends of the stage, right? Like as Dr. Mann was saying, you know, sometimes we do a multimodal approach. Fortunately for Mr. Dwyer, we found it so early that a surgery was the only thing that the patient needed. Sometimes we, you know, when we have these intermediate stages, we will do some immunotherapy plus chemotherapy to decrease the size of the tumor to get the cancer under control, and then, you know, our wonderful thoracic surgeons will remove that lung, and the patient may need some consolidated chemotherapy afterwards.
And sometimes you don't. I mean, a lot of it has to do with the type of tumor.
Absolutely.
And whether it's spread around the tumor or if it's, especially if it gets into the lymph nodes, the story changes pretty dramatically,
Absolutely.
pretty fast.
We have a question from Jeremy Yenser. Excuse me. Jeremy wants to know, how likely are we to see the lung screening criteria shift soon to your age, like breast cancer or colon cancer screening, instead of risk factors like having been a smoker?
I think that, you know, I think that we will see a change over time. You know, lung cancer screening right now is just capturing 60% of all the patients that we should be capturing. As we said, you know, we are still not capturing the family history. We are still not capturing, you know, even though we had talked here in the health system with our breast oncologists, you know, females have never smoked, but they got radiation to their chest. They have a 16-fold higher chances of developing lung cancer. So we need to do something to be proactive with these patients. Unfortunately, the guidelines have not reached this patient population, but, you know, we are trying to get creative.
And screening is not perfect, right? I mean,
Absolutely.
it's a CAT scan, right?
Absolutely.
And so you do a CAT scan, and you still have to have a certain size nodule even to see that. So the itty-bitty tiny things you may not see.
Absolutely. Absolutely. I think that, you know, but it's still extremely important. I think that at least at this time, if you meet criteria, please talk with your primary care. Here we have, you know, a wonderful screening program. You know, we have dedicated nurse practitioners that they will go over the risk and the benefits of the screening. You know, again, talk with your primary care, get referred to that, get your CT scan, because that's potentially a life-saving.
So what are the screening criteria? Who screens in?
So it's smoking, and again, it has been through many revisions. I think that, you know, depend on the smoking history, and now we have at age 50 to 85, right? Like all of these people will qualify if you have at least 20 pack years, so you had smoked at least 1 pack per year for 20 years. You will screen in, and you will be able to get that CT scan every year to hopefully catch the cancer earlier.
Okay.
Johnny has a question about cardio scores, and it's a two-parter. He wants to know how often cardio scores catch problems that don't involve the heart, and since cardio scores are relatively inexpensive, could that be a good option for screening for lung cancer?
Well, let's go to both Ash, Dr. Mann, and Dr. Basile. Dr. Mann, I want to first turn to you. We've talked about lung cancer. You find other things, too.
You do. The advantage of my position is that not only do I operate on lungs, but I also operate on hearts. And so it's not uncommon to find something incidental in either direction. Maybe you're doing a lung cancer screening, or you're worried that you have a coronary history of some kind. And then you do the calcium scoring, as we talked about here, and you do find something. I don't know that I've ever seen statistics on that, but I would say as a surgeon, I have seen it more than once, that we're looking for one thing and we happen to find another, and it's usually pretty fortuitous. Sometimes it's benign, but sometimes we're catching things just in the nick of time.
Yeah, it's a pretty big deal, and clearly, how many times do you see a lung cancer coming out of these cardio scans?
Now it's more and more frequent. I think that, you know, it's in the range of like 20% of calcium score will have something. Now not every nodule means cancer, and some of them they just need to repeat the CT scan in few months. And again, most of the nodules are probably not cancer, and there are some kind of infections or something like that, but need to be followed. Make sure that, you know, if they found a nodule in your chest, you don't forget about it. You go for your repeat CT scan. You make sure that resolves. If that resolves, well, fantastic, and if it doesn't, well, you know, we are here to try to help and try to diagnose it earlier and give the therapy that the patients need in order to, you know, have a better life.
Alexis?
What a great discussion. We have people who are just saying, I am so glad, this is from Mark. He writes, I am so glad that you're highlighting this topic. What a great resource we have in this community.
It is, and I do think it's been a great discussion, and I'm grateful to all of our guests for being here. Dr. Beaverhead, head back to the emergency room. But Dr. Mann, Dr. Postigo, thank you for being here on the program. Love to hear final thoughts from both of you before we end today. Dr. Mann, let's start with you.
Just really keep track of your health and know what your risk factors are. If you have a family history, like we've been describing, it may not be as high of a chance that you would have lung cancer, but certainly if you've been exposed to smoking or were a smoker yourself, worth just saying, do I need to get that screening? Because it really can save a life.
It really can, and it does matter. So talk to your primary care doctor and ask them, am I somebody who needs to do that screening? And to your point, it has to be done annually thereafter. Other thoughts that you have, Dr. Postigo? Final thoughts?
Absolutely. If and I think that the screening is extremely important. But also, if you go to the ER for anything and they found a nodule, don't forget about it.
Yeah.
Don't forget about it. Probably you were referred to someone, but you need to show up. You need to show up, and we need to follow that. Again, can potentially save your life.
Well, and as you saw just earlier today, he goes to the hospital, Dr. Mann, he has a surgery, he goes home the next day, and a few weeks later he's back in the gym. I mean, come on. That is not how it was when I started in medicine, and I promise you it's not how it is if you're going to get chemotherapy and radiation therapy. But all this comes back to the common theme we've had before: faith, hope, and science, and the impact on people's lives. You have to have faith in healthcare and in the system and the science around us. Hope, because there's always something we can try and to think about to help make you better, and even if it's at the end of your life, to be comfortable. And then science, because it powers us to change and save lives. And to be an academic medical center is a blessing, because you're around all these people who are thought leaders and at the forefront of the research and the things that are going to change those lives. Whether you're in the basic science lab or you're in the front lines, like Dr. Mann and Dr. Postigo. Thanks everybody for being here today. Remember, faith, hope, and science. Live long and prosper. Let's get back to Alexis Del Cid to hear what she's working on for tomorrow's show.
Dr. Stites, tomorrow on All Things Heart, we have another great example of all the collaborative care here at the health system. You'll meet a 26-year-old woman who's undergone several open heart surgeries for a congenital heart defect. Two of her doctors invite us into the procedure room to see how they work together to fix a narrowing pathway deep in her heart. That's tomorrow at 8 a.m.
All right, that is the best. And once again, you're going to hear that combination. When you see that report, you'll be thinking, hey, faith, hope, and science. Let's get that done. We'll see you soon.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.